Hi everyone, if you are new to the channel, my name is Ali. I'm a doctor working in NHS. And in this lecture, I'm going to introduce you to the vascular surgery. This will be very beneficial for you if you are an FY1 going to your vascular surgery, or if you are a medical student who are having a vascular rotation. To simplify the lecture, I want you to think about vascular as arteries, veins, and lymph channels. We're going to tackle each one separately. We're going to tackle the anatomy and the pathology of each. We will start with the artery. This is the arterial tree. Most important arteries you need to remember about this arterial tree is the ascending aorta will give you branches for the coronary arteries. These are the first branches of the aorta, which are responsible for supplying the blood to the heart muscle itself. The coronary arteries includes right coronary artery, which supply the right side of the heart, of course, and left coronary artery, which is split into the left anterior descending, the LAD, and the circumflex artery, supplying the left side of the heart. Then you have the aortic arch. The aortic arch will branch into brachiocephalic trunk, the first and largest branch of the aortic arch, which is further divided into right subclavian artery, supply the right arm, and branches into the right vertebral artery for brain supply. And it also gives the right common carotid artery, supply the right side of the head and neck. And the right common carotid artery will give you the internal and external carotid artery, the right one. Then you have the left common carotid artery coming from the arch immediately, supplies the left side of the head and the neck. And the left common carotid artery will give you the left internal and external carotid artery. And the last branch of the aortic arch is the left subclavian artery. Then the descending aorta will give you intercostal arteries, bronchial arteries, esophageal arteries, and mediastinal and pericardial arteries. And after the descending aorta will become the abdominal aorta, which will give you the celiac trunk, first major branch supplying the upper abdominal organ. The celiac trunk will give you the left gastric artery, splenic artery, and common hepatic artery. Celiac trunk usually branches at L1. Superior mesenteric artery, the second branch of the abdominal aorta, which are around L1. Renal arteries, gonadal arteries, and inferior mesenteric artery. Inferior mesenteric artery usually branches around L3. And then the aorta will bifurcate at L4. So how you can remember that one? The word bifurcate, 4 at L4, will give you the common iliac artery. The common iliac artery will give you the internal iliac and the external iliac. You have right and left common iliac arteries. Then the external iliac, each one will give you the femoral artery. The external iliac artery will continue and become the femoral artery after passing beneath the inguinal ligament. The femoral artery will give you the deep femoral artery, branches off from the femoral artery to supply deep structure of the thigh, and will give you the superficial femoral artery. Continue down the thigh and enter the abductor canal. Then popliteal artery, located at the back of the knee. The popliteal artery supplies the knee joint and surrounding area. The popliteal artery will give you the anterior tibial artery, travels along the front of the leg, eventually becoming the dorsalis pedis artery at the top of the foot or the dorsum. And also, the popliteal artery will give you posterior tibial artery, travel along the back of the leg, branching off the fibula peroneal artery, and eventually reaching the foot. Branches of the lower leg, anterior tibial artery, runs along the anterior front part of the leg. At the ankle, it becomes the dorsalis pedis artery, which supplies the dorsum of the foot. Posterior tibial artery, second branch, runs along the posterior back part of the leg, branches off into the fibular peroneal artery, which supplies the lata or outer side, which supplies the lateral aspect of the lower leg. Arteries of the foot, you have dorsalis pedis artery, continuation of the anterior tibial artery, that's important. And you usually check the dorsalis pedis pulse. It's a continuation of the anterior tibial artery on the top of the foot, the dorsal part. It supplies the dorsal aspect of the foot and gives rise to the arcuate artery, which supply the toes. Medial and lateral plantar arteries, branches of the posterior tibial artery. These arteries supply the sole of the foot. Plantar arch, formed by the lateral plantar artery and branch of the dorsalis pedis artery. It supplies the toes through the plantar metatarsal arteries and digital arteries. Histology of the artery. You have tunica intima on the inner side, then tunica media, and then tunica adventitia. Understanding this histology is very crucial and important to differentiate between dissection and aneurysm later on. Next, the arterial pathology. We will start with peripheral arterial disease. The chronic version is So I divided the peripheral arterial disease into chronic version and acute version. And by chronic version, I mean chronic limb ischemia. The risk factors for chronic limb ischemia includes hypertension, diabetes, smoking, cholesterol, and male gender. And why is male gender? Because estrogen is protective for ladies. Presentation. First presentation, leg claudication due to lactic acid buildup and substance P accumulation. In this case, rule out spinal stenosis because the spinal stenosis will present with spinal claudication. And what do we mean by claudication? If you are walking for a specific distance and then you feel pain in your legs or calves, that means claudication. Second presentation of chronic limb ischemia, non-healing wounds. Third presentation is rest pain. Fourth is asymptomatic but shiny shins and loss of hair. And why is that? Because when there is a reduced blood supply to the legs, the shins will be shiny and the patient will lose his hair. And lastly, decreased pulse and low temperature. So if the patient complaining of coldness in his feet, that may indicate chronic limb ischemia. Investigation. How you investigate chronic limb ischemia? Firstly, ABPI, which indicates ankle brachial pressure index. And it answers a simple question. Is there a problem? So if you found ABPI, and the idea is you measure the systolic blood pressure in the ankle and in the brachial artery, you divide the systolic blood pressure of the ankle with the systolic blood pressure of the brachial artery, and then you will reach an index. If it's less than 0.5, that's severe arterial disease. Compression stocking are contraindicated. You use compression stocking to avoid DVT. You don't use them for patients with APPI less than 0.5. If it's 0.5 to 0.8, that means presence of arterial disease or mixed arterial plus venous. Compression stocking should be avoided generally, but reduced pressure stocking could be used if indicated. If it's 0.8 to 1.3, no evidence of significant arterial disease. If it's more than 1.3, that means there's arterial calcification. And what are the diseases that may give you arterial calcification? Think diabetes, rheumatoid arthritis, renal failure, and systemic vasculitis. That's why care must be taken in interpretation of APPI, resulting people with this condition may be misleading. Compression therapy should be used with caution in people with diabetes who may have unreliable APPI due to arterial calcification as well as underlying sensory neuropathy. So when your patient normal score in APPI, that doesn't exclude chronic limb ischemia because the patient may have calcified artery, which gives you false normal APPI. Second investigation is ultrasound Doppler. An ultrasound Doppler answers the question, where is the problem? It will show you if there is stenosis or calcification in a specific segment of the artery. After the ultrasound Doppler, the third investigation is CT angiogram. It's more accurate and precise. After you do the CT angiogram, the next question you should ask, do I need to fix this patient? If your patient is elderly, 99-year-old, bedridden, then there's high chance you're not going to intervene surgically. But if your patient is 65 postman who's working fine, then you may intervene surgically. Very important clinical point. Before CT angiogram, check if your patient has contrast allergy, check the renal function test, stop the warfarin 2 days prior, check urea and electrolyte, and make sure the patient is well hydrated. How are you going to treat chronic limb ischemia? Treatment is a surgical or medical. Surgical angioplasty plus stent. This usually for above knee and short lesion, which makes sense. You need short lesion to angioplasty and stent. If it was long lesion, you cannot angioplasty easily. And then bypass, usually for the below knee and long lesions. And I'm going to show you the picture of the angioplasty so you can understand the general concept of angioplasty. Here the picture which simplifies the concept of the angioplasty. You go with the catheter, you dilate a balloon, you make the artery wider. Then the concept of bypass is either a vein or it could be synthetic like Dacron or a special material. And the idea is simple. You bypass the blood across the blocked artery. So you take the blood from the healthy artery on top and you bypass the blockade and you insert it in the lower part. And you have secondly the medical treatment, which you basically tackle the risk factor. For the hypertension, you give beta blocker plus ACI. Diabetes, you make sure your hemoglobin A1C less than 7. Smoking, you advise your patient to quit. For the cholesterol, you give your patient high potent statins. And you tackle the antiplatelet with aspirin and clopidogrel. For the pain relief, you give clystazole, which is phosphodiesterase inhibitor type 3, and bentoxofilin, which increases the RBC's flexibility. And when we're going to use this medical treatment, we're going to use it for the bedridden patient that we are not intervening surgically. But if the patient is surgically fit or can tolerate a surgery, we will go with the surgical option, as we showed in the previous slide. Now, the concept of critical limb ischemia. What is critical limb ischemia? Critical limb ischemia is chronic limb ischemia plus one of these. Rest pain, ischemic pain at rest for more than 2 weeks despite adequate analgesia, or tissue loss. And by tissue loss, we mean ulcers or gangrene. So if you have chronic limb ischemia plus rest pain or tissue loss, that's critical limb ischemia. This is the picture of dry and wet gangrene and the most important difference between the dry and wet gangrene. You can look at the image and you can look at the table, but mainly the dry gangrene usually is not infectious and we are not too worried with the dry one. The wet one is usually infectious and can cause sepsis, so we treat it aggressively. And the idea of the wet and dry gangrene, just to classify them, but usually they will be mixed, dry and wet, both together. So think of them as spectrum, not as a dry or wet. And we also have gas gangrene, which caused by Clostridium perfringens, most commonly. As the picture shows, there's in the dry there's arterial occlusion, in the wet is more venous. Macroscopy, in the dry organ is dry, shrunken and black. That will the wet one will be moist, soft, swollen. The most important differential is the line of demarcation. In the dry one, there is clear line of demarcation, but in the wet one, there is no line of demarcation. Presence of bacteria. The dry one, the bacteria fail to survive in the dry, but numerous bacteria can survive in the wet one. Prognosis, general better due to little septicemia, that's a dry one. The wet one generally poor due to profound toxemia. How we diagnose the gangrene? Of course, you see it. And the treatment, we try to fix it medically. If not, we amputate. We finished the chronic limb ischemia. Now we're going to speak about the acute limb ischemia. The pathology, there is no time to develop collaterals. The clot will happen immediately. And the pathophysiology, usually it's a cholesterol embolism following a catheter, or clot embolism for the patient who has atrial fibrillation, or it could be thrombus formation, peripheral vascular disease with thrombus on top of the atheroma. It's acute on chronic limb ischemia in this case. So you have chronic limb ischemia and there's a thrombus on top of the atheroma and acute limb ischemia. Presentation, usually the patient will present with the 6 B's and think no blood to remember them. Don't memorize, understand. If there's no blood, of course there's no pulse. So pulseless, pale because the blood color is red, bicoilothermia, which means coldness, blood distribute the temperature around the body, pain because the lactic acid substance B will accumulate due to anaerobic glycolysis because there's no oxygen coming, because there's no blood coming, paresthesia and paralysis. These are the 6 P's. To investigate, you need you do ultrasound Doppler, not the ABBI. Why? Because it's acute event. The ABBI will not be helpful because the ankle brachial pressure index usually measure the chronicity. Okay, and remember you have 6 hours to treat acute limb ischemia. How are you going to treat it? With embolectomy or intra-arterial TBA? I'm going to show you the picture of the embolectomy in a second. Be aware of compartment syndrome due to the perfusion injury. If that happens, then you need to do fasciotomy. And usually this could happen after the embolectomy or intra-arterial TBA. Here the picture of the idea of the embolectomy. You go with the catheter, you bath the block, and then you inflate the balloon and you drag the thrombus out. That's the embolectomy. And by this, we finish the most important 2 arterial pathologies, acute and chronic limb ischemia, A and B. Now we are in C, Berger disease. We call it also thromboangiitis obliterans. It typically affects young smokers, affect medium and small size arteries and veins. Peripheral neuritis is also seen, so your patient may present with numbness. Corkscrew, collateral and trapped occlusion of the medium-sized arteries with no distal reconstitution. But this is not pathognomic. I'm going to show you the corkscrew collateral in a minute. It's not reconstructable. We cannot bypass it. We cannot put a stent for it. That's the meaning of not reconstructable. I'm going to show you the picture of the corkscrew now. This is how Berger looks. And this how Berger looks on the Doppler on B and C. And on the arteriogram on A. There's a corkscrew appearance. And before to move to the next arterial disorders or pathologies, I would like you to have a good look at this picture because it's give you an idea about the rest of the topics that we're going to speak about. So as you can see, A is a normal vessel, has intima, tonica intima, media and adventitia, as we showed in the image in the early of the lecture. And then you have true aneurysm and false aneurysm. The difference between the true aneurysm and the false aneurysm, the true aneurysm, all the layers including tonica intima, media and adventitia will be blocked out, as you can see in the picture B and C. And in the false aneurysm, not all the layers are bulked out. There is a tear just before the tonica adventitia. The true aneurysm and the false aneurysm, the true aneurysm is divided into saccular and fusiform. Saccular is like a sac, so it just plugged on one side, as you can see in picture B. The true aneurysm, the bulk is on both sides. And the false aneurysm, as we said, there is extravasation of the blood contained by the tonica adventitia. Dissection is totally different than the false aneurysm. Dissection means there is a dissection in the tonica intima. So the tonica intima is dissected. I think the most difficult to differentiate here is the false aneurysm and the dissection. False aneurysm, the tonica adventitia contains the blood. Dissection, the tonica media contain the blood. That's the difference between the dissection and the false aneurysm. Now we can speak about the abdominal aortic aneurysm. The pathophysiology is atherosclerosis, and we divide it into true or false, saccular or fusiform, as I showed you in the previous image. The presentation, usually it will be a more than 65-year-old male who smokes or smoked before. Usually it's asymptomatic pulsatile mass In practice, usually we discover it incidentally. Your patient will present with right upper quadrant pain. You do ultrasound to discover the gallstones or to diagnose acute cholecystitis, and then you will find dilated abdominal aortic aneurysm. Investigation, abdominal ultrasound. This is how we can screen too, but the definite one is CT angiogram, not arteriogram. Why arteriogram is not the right answer? Because in the arteriogram you will not be able to see the dilatation. You will not be able to see the aneurysm. And to define an aneurysm is 1.5x the normal diameter of an artery. If you have an artery that's normally 1 centimeter, in order for it to be aneurystic, it has to be 1.5 centimeters. So 1.5x the normal diameter will make the diagnosis of aneurysm. In order to treat, you need to know the size you need to know the diameter, of the aneurysm. If it's more than 3.5 centimeter, that's a diagnosis of AAA, abdominal aortic aneurysm. In this case, you screen every 12 months. If it's 4.5 centimeter and less than 5, that's AAA, but you screen every 6 months. If it's more than 5 centimeter or the rate of the growth was more than 0.5 per 6 months, then you treat it surgically. If presented with a tender mass and backache, then the treatment is surgery. There's no survey here. Why? Because it's symptomatic. So symptomatic abdominal aortic aneurysm, treatment surgically. Your option for the treatment are EVA or open surgery. What do we mean by EVA? It's endovascular abdominal aortic repair. And open, you literally do open surgery to fix the artery. I'm going to show you the picture of the boss in a minute. This is the aneurysm from inside, and this is a CT scan for the aneurysm, 9 centimeter aneurysm. It's very clear, very obvious. It's here, as you can see. This is the way we treat it. We treat it with a graft. As you can see, you have a graft on your right hand side. This graft extends from the renal down there, containing the whole aneurysm. This graft, if you can see the neck of the abdominal aortic aneurysm, if this neck is very close to the renal artery, in this case we do what we call fenestrated abdominal aortic repair. And why we do that? We want to supply blood to the renal arteries by creating fenestration. That's the brief idea of abdominal aortic aneurysm. Next, we're going to speak about the aortic dissection. Pathology is a tear into tunica intima, as we said earlier. Risk factors: hypertension, Marfan syndrome, syphilitic aortitis. Presentation: usually your patient will present with tearing chest pain that radiates to the back. Asymmetric blood pressure. Any chest pain, do bilateral blood pressure, because the chest pain could be aortic dissection. And you will find widened mediastinum. Investigation: if no renal impairment, do CT or angiogram. You will see the false lumen. If renally impaired, you can do transesophageal echo or MRI. Arteriogram is the wrong answer, because arteriogram will not show you the false lumen, will not show you the dissection. You can see here, this red arrow shows you the dissection. The part of the artery that's close to the heart, that's a false aneurysm, and the other part, that's the true aneurysm. This picture clearly demonstrates the aortic dissection. The treatment of the aortic dissection depends on the type. For type A, operate and evaluate for aortic valve replacement. For type B, and I give you a nice mnemonic here, type B is below, IV beta blocker to decrease heart rate and blood pressure. There's an image I'm going to show you now. This image will show you how you can differentiate between type A and type B. And this mnemonic will make sense when you see the next picture. With the picture here, you have type B and type A. Type B is below, anything below the aortic arch, below the subclavian, specifically the left subclavian. That's type B. Any aneurysm above that is type A. Type A is divided into type A1 and type 2. And type B, also called type 3. Here's another angle. As you can see, the dissection is very clear. Next is a carotid artery disease. The pathology is the stenosis of the internal carotid artery. Presentation, transient ischemic attack, which is stroke that resolved in less than 24 hours. Miosis vagus, which is transient visual loss or blurring, and stroke. Investigation of choice, diagnostic cerebral angiogram, that's an old modality now. MRA is the answer. If you've asked what's the best investigation for carotid artery disease, is MRA. If the stenosis is significant, more than 70%, then you treat. Significant stenosis, carotid endarterectomy within 2 weeks of symptoms. That's the window period of the treatment. If it's asymptomatic or less than 70% and non-significant stenosis, meaning less than 70%, best medical treatment, including lifestyle modification, control risk factors, antiplatelet, and statin therapy. The surgical treatment is carotid endarterectomy, and this image basically simplifies the carotid endarterectomy. And simply, you just clap the common carotid artery, the internal and the external. Obviously, we're targeting the internal. As you can see, there's a plug, yellow material. And then we cut it open. We put a conduit that transfers the blood to the internal carotid. Internal carotid ultimately supplies the brain, and the brain cannot survive more than 4 hours without blood. You take the plug out and you resuture back, as clearly demonstrated in this image. And by this, we finish the artery. We're going to tackle the vein next. Most important disorder of the vein is varicose veins, which is more than 3 millimeter in diameter. That's the cut line of diagnosing a varicose vein. Pathology is incompetent valve in the perforating veins. You have a deep venous system and a superficial venous system that's connected with perforating veins. The valve of these perforating veins, when it's incompetent, that will cause the varicose vein. Risk factor: age, female, pregnancy, obesity, prolonged standing, and previous DVT. Presentation: dilated veins, itching edema, burning, restlessness leg, and venous ulcer. Examination: TAP test, cuff test, and Trendelenburg test. You can Google each of these. Investigation: venous duplex ultrasound. You have arterial duplex for the peripheral arterial disease and venous duplex for the varicose veins. Treatment of varicose veins, medical and surgical. Medical, you're gonna tackle the risk factors. That's why we mentioned them. Weight loss, exercise, leg elevation, and compression stocking. Before you apply compression stocking, make sure your patient has no arterial disorder or peripheral arterial disease. Exclude arterial disease before using compression stocking. That's a very important clinical point. Surgical treatment for the varicose vein: endothermal ablation, sclerotherapy with foam, and stripping of the veins. One of the most serious complications of varicose vein is venous ulcer. And this picture is high yield and may appear on your OSCEs. Whenever you see an ulcer on the medial malleolus, that's possibly and most accurately a venous ulcer. That's a diagnostic, or if I said, what's your spot diagnosis seeing this picture, is a venous ulcer. And this lecture will finish with lymph channels. Most important pathology of lymph channels is lymphedema. Pathology: accumulation of lymph into interstitial space, an accumulation of debris and protein buildup. Macrophage will come and release cytokines. This will lead to thickening and fibrosis. Causes is either secondary or primary. Secondary in developing countries is filariasis, which is nematode infection. Commonest cause is Escherichia bankrofti. In developed country, that's usually due to malignancy, primary lymphoma or METs, and lymph node dissection. This picture shows the lymphedema. Second type is the primary lymphedema, usually congenital. We call it Priox before 35-year-old, and we call it lymphedema tarda after 35 years old, usually associated with Turner syndrome XO. Diagnosis is usually late, thus we follow the WHO grading. You can just Google it. The most important sign for lymphedema is stima sign, which means you cannot pinch the skin. If you try to pinch it, it will not be, it's unpinchable. That's stima sign. In the initial stage, there will be pitting edema, and in the late stage, there will be non-pitting edema. In the late stage, there is non-pitting edema because the fibrosis will build up. And the last slide is how to treat it, how to treat lymphedema. It depends on the grade. You can use compression bandages, lymphatic massage, and compression stocking. Surgery, reduction surgery, and liposuction, which basically you go subcutaneously and you try to reduce as much as you can from the tissues and fibrotic tissues beyond the skin. And this will summarize all the like this an introduction for the vascular surgery. We spoke about the arteries and the most important disorders, veins and the most important disorders, and lymph channels. Good luck and see you in the next video.